Sorry to interrupt the very interesting discussion, but it's a lot of COVID. So let's go back to our real passion of cardiac electrophysiology, and welcome to this session, web series sessions of newer advances, recent some new things, new technological developments. And without wasting any more time, I would invite Dr. Sanjay Dikshit to please take over, moderate the session, start the proceedings, and the panelists to join him. Preeti, if you could put everybody on mute, please. Preeti, have you put everybody on mute? Okay, I request Dr. Sanjay Dikshit to kindly unmute himself and please take over the proceedings. Thank you.
Thanks, Vinitha. This is really wonderful, first of all, to see you looking nice and healthy, and I'm glad that, that disease is behind you. And I hope that, you can really bend this curve, because it just is terrible what you all are going through. But today,
Dr. Sanjay, you have to unmute.
Yep, better. Yeah, so it's really a pleasure to introduce you to the faculty that have agreed, and I'm very grateful to them for joining us this morning on a Saturday. We've heard from many people in the last 11 months or so of this ongoing educational series, and what we are going to hear from today are, I would say, the new leadership in cardiac electrophysiology within the US, and these young faculty members. They're really sort of taking just a very different approach to cardiac electrophysiology, and some of the work that they have done, I think, will inspire us all and kind of show us what's the future of cardiac electrophysiology. So the sessions are planned where each speaker will have about 15 to 18 minutes to give their talk and about 3 minutes of Q&A. But then I would ask the audience to please send in the questions, because we have a 20 to 30 minute panel discussion afterwards where we hope to field the questions that we couldn't answer during the presentation. So with that, let me start with our first speaker, Dr. Jacob Koruth. He is Associate Professor at Mount Sinai in the EP section there, one of the founding members of the group that is now driving cardiac electrophysiology in the US, and together with some of his colleagues, Vivek and Srini, they have done some really amazing work. Jacob himself is very interested in complex arrhythmia ablation, but he also directs the experimental lab at Mount Sinai, which has done some really cool things with industry, and some of the work that he has done on animal models there has led to the clinical stuff that we all are benefiting from. So today I asked him to present to us some of his own observations on pulse field ablation for treating atrial fibrillation. And Jacob has been involved both in developing the technology in the animal model, and then actually participating in some of the clinical trials, which is really bringing this new tool for clinical use very soon. So Jacob, please take it from here.
Okay. Sanjay, thank you for the introduction. And a big thank you for the organizers for this invitation, and to all the panelists and everybody who's taking time to be here today. So my task is to talk about pulse field ablation for treating atrial fibrillation. All right, give me a second. Let me see why it's frozen. Not a good way to start. Okay, there you go. These are my disclosures, and I'll sort of skip right through this. So I want to spend a few moments just to talk about pulse field ablation, and really, what is pulse field ablation? Really, the key words are the use of ultra short, very high voltage electrical impulses through a catheter. This creates very large increases in the electric field across the cell membrane in particular. This makes nanoscale pores, which when they become permanent, cause cell death by various mechanisms detailed here. So that's how it creates an ablation lesions. The important concept here is that it's killing tissue without using thermal energy. And there is a sort of a zone in which this energy actually leads to cell death. But it's important for us, while we use this energy, to stay within this irreversible zone. If you use too little of energy, you cause reversible changes, and that's not good. And if you use too much, you actually create heat, and it starts looking like radio frequency. So this concept of staying within the right zone to achieve the endpoint is an important concept that is different for every catheter that's being designed. Trying to understand how it creates a lesion, the two key concepts are the lesion is determined by the intensity of the field, and that field develops right at the moment the pulse is delivered. And it's not just the field, but how much of the field gets into the tissue that's being targeted. So both these concepts are very important in understanding how the lesion is created. And specific to PFA, which is why I think it's going to be a huge thing in the atrium specifically, is that there is a tissue-specific threshold, meaning you can kill myocardial cells fairly easily, whereas you have to work really hard to kill all other kinds of cells, which is why PFA has this alleged magical dissociation between efficacy and safety. Another important concept, the tissue scaffolding is not destroyed, so the structure of the ablated tissue remains intact. You're literally sucking out the myocardial cells and putting in collagen there without destroying the scaffolding, which is very different from radio frequency and somewhat different from cryoenergy. Lots of technical details with PFA that define this tissue field interaction. So lots of things that you can change. It's not like radio frequency where you have power, duration, and impedance. There are many things that govern how a catheter delivers energy and what the tissue response is. And it's different for every catheter, unlike radio frequency where the only difference is the footprint of the catheter. A few words about the biology of PFA, and it's important to appreciate this because this is how it's going to distinguish itself in the coming years. The monophasic waveform, think of a defibrillation impulse. This is the old approach to PFA. And as you can imagine, you have a lot of electrical artifact. And in this particular early experiment, you can see how you get ST depressions and ST elevations instantaneously. So it's not from coronary spasm or injury, it's just an electrical phenomena. This is not seen with biphasic modern waveforms. Another thing that's very unique about PFA, it's instantaneous electrogram attenuation. So immediately after an impulse, you see all these EGMs just vanish. And this is also associated with increasing pacing thresholds. So there is an acute electrical effect that very soon results in tissue injury. So there's no, it's not a magical phenomena, but this EGM attenuation is so remarkable that it's a very characteristic trait of PFA. Because we are using a field to kill tissue and not heat, we all know that when we use radio frequency, if you burn across a cool structure, you can't hurt tissue. And this is an example of burning across the mitral isthmus. And you can see how the coronary sinus, despite a big lesion, is completely spared. This does not happen with PFA. As long as that zone incorporates the coronary sinus, you will see a lesion. And this is an example of PFA to the mitral isthmus in a swine model. And you can see the same lesion in the LA, but look at the coronary sinus. The roof of the coronary sinus is completely ablated, and there's no issue here because there's no competition that leads to loss of thermal energy, which is why you get sparing with radio frequency energy. So another key concept that I think will make PFA special in the atrium. People need to also appreciate that this is not a type of energy that kills tissue over time. It's fairly instantaneous. And you can see this when you do experiments, when you deliver PFA and you see actual swelling of the tissue and echogenic changes, much like radio frequency. So you can see how you can track lesions, especially in thicker tissue, by looking at ICE images. Another concept, I already talked about how it's important to stay within the irreversible zone. But every catheter has a thermal footprint, and you'll only know it if you have a mechanism to measure it. What's important to appreciate is that this thermal footprint is very small. And in this preclinical experiment, using one catheter that has a capability of measuring it, you see you get slight increases in temperature that is particularly pronounced in narrow veins and not in large chambers. So there is a thermal spillover, but not the mechanism by which you're creating an ablation lesion. Another important concept based on the field is how PFA can kill tissue within a zone. And I like to show this slide because no other technology can ablate trabeculae and cords and tendons as well as PFA, because as long as this cord is within the tissue, it'll get ablated. And I think this will be particularly helpful for certain kinds of arrhythmias that we'll target in the future. A few minutes on preclinical overview, focusing on what's been done. A lot of the work comes from the Netherlands, from Dr. Van Driel, Kars Nevens, and Witkamp. These are the people who led the field, and they demonstrated using animal models that you cannot cause PV stenosis, you cannot damage the esophagus, and you cannot damage the phrenic nerve. But remember, this is all at a certain dose. If you push it hard enough, you can create cell death, but the kind of injury that leads to fistulas will, in my opinion, never really happen because the scaffold is never disrupted. We started our journey with PFA many years ago, and I still remember the first endocardial ablation that we did in an animal model, and I actually thought that the catheter came disconnected, and it's very remarkable how the EGMs vanish acutely. What do the lesions look like? Most of our catheters today are big catheters, so the lesions are big, but the characteristic signs are very homogeneous, non-hemorrhagic, non-contracted scar tissue. And that's why the efficacy of this approach is going to be high, because you have broad lesions and the chances of gaps are going to be lower. Histology, very characteristic things, very consistent fibrosis. And you look at this nerve right in the middle of the fibrosis, completely spared. Look at this big lesion in the ventricle and look at this epicardial coronary artery, completely spared. So, it's not like this energy won't damage it at all, but predominantly it tends to spare collateral organs at the clinically relevant doses. So again, very characteristic of PFA, not seen in any other technology. And this is just a comparison of a left atrial tissue where we made a PFA lesion on the left and a radiofrequency lesion on the right. This is at 2 weeks. And you can see how much more advanced the replacement fibrosis is with PFA, whereas with radiofrequency, you still get patchy destruction. There's a lot of hemorrhage, the fibrosis that's at different stages. So the scar that you'll get with PFA and radiofrequency is going to look different in the early days. Let's move on to clinical overview, because we're supposed to talk about atrial fibrillation. And in the clinical arena, the first catheter that was developed that actually did work was an epicardial system. Again, work that started off in the animal lab, demonstrating that you could use this loop to isolate the entire posterior wall. And early clinical work suggested that this could be achieved, but very quickly everybody realized that the only solution in the world of AF is to have an endocardial system. And most of my talk is going to revolve around two catheters that I have had experience with, and that doesn't mean that there are other catheters out there. So the pentaspline system that was designed as a one-shot approach to pulmonary vein isolation is a catheter that goes over the wire and takes two forms, a basket form and a flower form. How does this catheter work? You get left atrial axis, and then over the wire, you deploy the catheter here in the basket form, here in the flower form, advance it, you ablate, and then you move on to another vein, pass the wire, expand, push forward, and ablate. The early data went through many stages. So they started off with a monophasic waveform, and it was magical. Every vein that was ablated, isolated. and we published our early experience. But what we realized was, despite everything looked really grand acutely, things really didn't pan out at 3 months, and there were a lot of reconnections. And that led to many iterations of a biphasic waveform, which does not cause a lot of muscular contractions, which is a very important concept, because with monophasic, you needed paralysis. And with biphasic, you could do this under sedation, which is a huge thing for AFib and workflow, patient comfort and volume that you can actually pursue with PFA. And in this series of patients, we were able to demonstrate really good 3-month durable isolation rates. And when you look at the data, and a lot of this data comes from Vivek Reddy and Pierre Jays in Bordeaux, this is a lot of work from Europe. And what they show is with every iteration with dosage and to the final dose, up to 98% of patients were durably isolated without paying a penalty in terms of esophageal injury, strokes, phrenic palsy. And this is what sort of led the whole field to say that, wait a minute, we finally have an energy source that can get us really high efficacy without paying a price from a safety perspective. And this is just a picture to emphasize how uniform the lesion is acutely after an ablation. Pictures of pulmonary vein delayed enhancement that you won't see with any other technology. It's also been investigated in persistent AF, initial multi-center single-arm study. Again, the same authors. This is work that we did in Europe, where we are using 2 different catheters, making PVI, posterior wall lesions, and linear lesions. And the scoop of the whole thing is that with an addition of 10 minutes of ablation to the posterior wall, we were able to isolate not only the veins, but the posterior wall after we got to the right dose consistently, again, telling us that PFA can be a solution for persistent AF, especially if the catheter is amenable to make lesions outside of the pulmonary vein. So that was the one-shot approach, which can be used to do the posterior wall. But all of us want a catheter that we can move around. And thankfully, the lattice ablation catheter, which was designed as a catheter that has a big footprint that creates radiofrequency lesions, was also used to deliver pulse field ablation lesions, allowing for really cool flexibility and a platform that we are all familiar with. And essentially what this catheter does, initially we thought we should just use pulse field on the posterior wall to protect the esophagus and radiofrequency on the front wall, because these lesions are so quick and deep. But now we're also looking at trying to do the whole atrium just with pulse field ablation. And you can see how this catheter can be moved just like any other catheter and create these big lesions that allow us to zip through this case really, really quickly. The early experience involved a mix of patients with paroxysmal and persistent AF. Some of them got a combination of RF and PF, and some of them got only PF. This was acute data. There's a lot more work that'll be shared in the coming months where we're doing only PF and looking at chronic outcomes. And I think this approach is going to allow us to do a lot of cool things that we currently find difficult to do. Like imagine doing a mitral line in under 2 minutes and getting durable block. Sanjay, do I have more time?
Yes, please.
Okay, great. So I want to sort of talk about a comparison between PFA and radiofrequency. And I think this will help you understand the technology a little bit better. Remember with PFA, it's the current and field that's most important, and contact is important, but not as much as in radiofrequency, where it is the current and contact that is equally important. We talked about the several variables involved in PFA and radiofrequency. We already know what these variables are. The tip design is very important for PFA as it is for radiofrequency. As of now, there isn't a lot of titration. You can't make a small lesion and then make it bigger. It's either or. Whereas with radiofrequency, it's a little bit flexible. I don't think this is how it's going to be in the future. There will be some amount of flexibility, but not a real-time flexibility with PFA. The duration is obviously very short. The stability with PFA can be challenging if you have a lot of muscular stimulation, but I think with modern biphasic waveforms, that won't be an issue. The electrical effect is far bigger than cell death, which is why proper dosing studies and 3-month remapping is going to be very important in PFA. We really don't know of a way to acutely assess durability because pace capture in adenosine may not mean as much with PFA as it means with radiofrequency. No destruction of tissue planes, edema in both, no heat sink in PFA. There is a reversible dose of PFA, and I think this is going to be very exciting. That can lead to a new approach to arrhythmia mapping called pulse field mapping. And the efficacy and safety are somewhat decoupled with PFA, whereas with radiofrequency, as you get more aggressive for higher efficacy, you pay a safety penalty. I want to stop here before I overload everybody with a lot of information. The status right now is two IDE studies in the US looking at PFA. One is Advent using the pentaspline catheter. The other is called, I forget the name, Pulsed AF, which is a Medtronic catheter, again using a circular shape for PVI and posterior wall ablation. And there's lots of exciting first-in-man work going on in Europe that will ultimately come to the US and help us understand how quickly can we get done with AF cases in a safe manner. And one more comment, I don't think PFA is only going to be a solution for atrial fibrillation. I do see it as a solution for other arrhythmias, although there are many, many questions that remain to be answered. I'll stop there and hand it over to the rest of the speakers.
That was terrific, Jacob. Thank you for sharing your work with us and for that very quick yet thorough overview of a technology that I think is really the future of arrhythmia ablation. So there are a few questions that have come up, and I'll just give them all to you, and then you can answer them in any order. So there's a question about the safety of focal ablations, given the observation that when you deliver energy, as you showed in that model where the CS roof is not spared, what's the safety of that? There was a question about the capability of this tool to create atrial versus ventricular lesions. I thought you talked about that a little bit, but perhaps you can expand on that. There's also the concern expressed regarding, the kind of lesions that you showed, which are obviously very impressive, yet around the veins, it doesn't lead to stenosis in the long term. So the audience is curious about why that's not the case. And then when you're using the lattice catheter to map, especially point-by-point ablation around the veins, how do you get feedback? Because you did mention that contact has some role in efficacy. So how do you work around that? So I threw a lot at you, and if you could address them.
So questions about safety. Right now, PFA almost seems like something that cannot be unsafe, but we know nothing is that perfect. And there is a chance that we'll find effects in the future that tell us that the scarring is of a different variety. But as such, as long as the catheter is manipulated safely, I don't think at reasonable doses that will hurt tissue in a different way. In fact, people could do too much ablation and that may be an issue. In terms of ventricular lesions, in normal myocardium in animal models, we can make really deep lesions, but how this will play out in the ventricles, we still don't know. I think it's clearly a solution in the atrium, but in the ventricles, for deep lesions in scarred VT, time will tell. I doubt whether a single dose can get through a large amount of depth endocardially. And I think radiofrequency will likely play a big role for scar VT, but we may be proven wrong. For certain kinds of VT, like PVCs and papillary muscle VTs, as long as depth is not an issue, PFA will be able to help. You can't target PFA into a direction you can't capture it into a narrow zone like radio frequency does. So I think those are some limitations, but overall, I think PFA will eventually find its way into the ventricle. What else did I need to talk about?
No, that's
Contact.
terrific, Jacob.
Yes, we're
Yes,
talking about
yes.
contact. Contact is very important. If you don't have good contact, the electricity is just going to leak into the blood pool. And most catheters today don't have a contact assessment. You have to use fluoroscopy or ice. But the lattice catheter, because it can tell you temperature, we can use the non-relevant temperature increase to tell us that there is contact. So I think that's an advantage. And I think future point catheters will need to come up with a mechanism to figure out contact for us to make sure our ablation lesions are good. Because if you make a bad lesion, you won't know upfront. So you want to optimize things before you deliver PFA.
That was terrific, Jacob. Thank you very much. There are a few other unanswered questions, which I'm sure we'll take up in the panel discussion. So with that, I'm going to move on to our next speaker, Dr. Jeffrey Arkles, who's a colleague at Penn. Jeff did his undergrad training at Johns Hopkins and then did the rest of his medical training at Penn, which was great for us because he has been a contributor to the cardiology division right through his residency days. And we were very fortunate that he decided to stick it out with us when he started as faculty. Jeff has several interests and he's part of the group and does a lot of the clinical work that we do in general. But in the last 3-4 years, he has developed this interest in stereotactic radiation therapy for treating cardiac arrhythmias, particularly ventricular tachycardia. He is involved with the oncology department in developing a protocol. He has done some translational work in small and large animal models. He's also done several patients that we have struggled with despite our group's effort and how we feel about VT ablation. We do end up with patients where we are just not able to get rid of the arrhythmia, and that's where Jeff has been sort of pivotal in getting these patients to a better place. So I'm welcome him to share with us his experience on this particular modality in treating ventricular arrhythmias. Jeff. I think you're muted, Jeff.
Thanks so much. Thanks for the introduction, and thanks so much for having me here. And all of our thoughts go out to India right now, and wish everyone the best there. I was going to talk about our experience in cardiac radiotherapy for the treatment of VT. And I was going to just start with a case just to describe the type of patient we're looking at currently. I want to go over some of the early studies and preclinical work, the pivotal trials, the Penn experience, in summary. And if we have time, the mechanisms, which I think are really fascinating.
Hello.
Jeff, sorry to interrupt you. I think there is some problem with the sound.
Yeah.
Okay. Let me see. Is it a low volume type of problem?
Yeah, so I think now it's a little better. So maybe
Okay.
I guess you need to be closer to the computer, or
I'll lean into the computer. Let me know if I do that again. Sorry about that. So I was just gonna. This is a patient we actually treated recently, and she was a 69-year-old patient with a non-ischemic or valvular cardiomyopathy, a history of a mechanical mitral valve with an ejection fraction of 15 to 20%. She had class 3 heart failure symptoms, cardiac ataxia. Her resting systolic blood pressure was usually in the 70s to 80s. She had VT since 2019. She was initiated on amiodarone. In 2020, despite the amiodarone, she was having shocks and had her amiodarone increased. Mixolydian was added. She had a VT ablation in November of 2020, which was very skillfully done. However, it was complicated by hypertension, hypoxemia, acute kidney injury. She spent 7 days in the ICU afterwards on various pressors, and had a 15-day hospitalization. And then she had a VT ablation in January of this year for recurrent ICD shock. This is what her heart looks like. So the first two images here are MRI, and you can see a very dilated left ventricle and short axis with a rim of delayed enhancement involving the entire septum from the inferior wall up to the anterior wall with some ICD artifacts. And again, in this view, you can see that same delayed enhancement. This is just one frame, maybe not the best frame, of an echo image showing a mechanical mitral valve with a massively dilated left ventricle. That's actually a movie. Her heart's just not beating. No, I'm just, it's a still image, but this is her VT ablation, and this is really the challenge for these types of patients. On the right here, show 6 different VT morphologies, and as you can appreciate in the inferior leads, that we have exits both from the bottom of the septum and the top of the septum, in a very large scar. And during these procedures, as you all know, we have challenges both in maintaining hemodynamic stability, and then we also have challenges with the ablation itself. Often these patients are given 3 liters or more of saline with the ablation, and it's a very destabilizing procedure for patients with advanced heart failure. So in summary, this patient had advanced heart failure with a poor long-term life expectancy. If you put her into the Seattle heart failure model, looking at 30–40% mortality at 1 year. She had VT refractory to amiodarone, nextosine, and catheter ablation. Epicardial ablation wasn't entertained due to the she actually had several prior cardiac surgeries, not just the one for the mitral valve, and it was felt that the pericardium wasn't a reasonable response to access. The ablations were challenging both due to the large substrate and the poor hemodynamics. She's not a heart transplant candidate due to age and prior surroundings. And what are the options? And there are always sessions at every conference and VT symposium about what the options are. And what we decided to do with her was cardiac radiotherapy. And on the right here is what's called an isodose map. And this is actually not this patient. This was I didn't actually have her plan available for this, but this is showing where dose is delivered and the gradients of reduced dose that are delivered to other organs. So after I'd seen this patient, I conferred with another electrophysiologist who also agreed that this was appropriate to consider. I reviewed her case with a radiation oncologist. We performed a planning CT with contrast. I sat for about an hour choosing the area to treat. About 2 days later, after a medical physicist found the safest way to deliver that radiation dose, we gave the patient 25 gray. The treatment itself took about 4.5 minutes. It was painless, non-invasive. She walked on and walked off the treatment table with no appreciable recovery. And today, although it's just a few months, she's not had recurrent VT. And this is where I think cardiac SBRT can be so useful. So what is SBRT? And it's stereotactic body radiotherapy. And it's a method of delivering highly focused radiation, typically with sub-millimeter accuracy to targets within the body. How does radiation affect myocytes, or how does radiation affect any cell in the body? And it's very complicated, and there are textbooks on this, and I'm far from the expert on it. But in general, we think about radiation causing double-stranded DNA breaks, and then cells dying off from apoptosis. And that's generally a process that takes about 6 weeks to occur. And how does radiation affect the heart? And I'll get into this more if we have time for it, but I think this is a really, really interesting question. It doesn't seem to be, at least at the 25 gray dose that we're using, that it's leading to dense fibrosis. Rather, it's changing the electrophysiology of the substrate. And so this is the first in human experience. So this was Billy Liu and Paul Zai out at Stanford, who treated a very ill patient with refractory VT. This is the map here. These were his VT episodes. And this was using a different system than we're currently using, and some of the other groups are currently using. This is a CyberKnife system, which is using gamma radiation rather than X-rays. This was based off some preclinical work that goes back to 2010 or even earlier. And these were some porcine dose finding studies where they delivered small amounts of radiation, increasing them, look for fibrosis intensity. And right around 25 gray was where people started to see fibrosis. Other people went on to do more work with, including at Mayo Clinic, with AV node ablation. And it seemed 25 gray was where electrophysiologic effects were started to be seen, and around 30 to 40 gray is where reliable heart block was seen, and dense fibrosis was seen. And then the really exciting thing happened when the group at WashU did a clinical trial, and if any study makes it into the New England Journal with 5 patients, it's usually a pretty big deal. So this was back in 2017, where Phil Kuselich and Cliff Robinson took 5 patients with refractory VT, treated them on a Varian Linac system using X-rays. And I'll go into why that's important, and had a very good improvement in patient outcomes. This was Encore VT, which was the same group with a follow-up study, showing that, again, in a very sick refractory population, there was a good antiarrhythmic effect seen with this approach. However, not all of the experiences have been so promising. So this was Star VT, and this was a different system. This was, again, the CyberKnife system, which uses gamma rays and a different modality to do cardiac gating. And it was the Amin Alathad and the Texas Heart Group who performed this. And their results were disappointing. They didn't seem to have a durable effect, and many of their patients recurred in the 6 to 12 month range. This was the experience from UCLA and the group there, which showed modest effect, but not some recurrences and maybe not as promising effects that we saw with the WashU study. And so I think there's been some skepticism on the part of electrophysiologists when they look at these really amazing results from WashU and then some more disappointing results with other groups. At University of Pennsylvania, we started a program with myself, our department, and the radiation oncology department. And these are just the first 10 patients that we treated. And this was a very sick group. Most of these patients had VT storm. They had an average of 2.5 ablations, the majority of which were performed at Penn, so very high quality or even heroic ablations. All had failed antiarrhythmic drugs. And the most common indication for treatment was recurrent VT despite best reasonable ablation. Some patients were offered this when ablation was contraindicated, even in the setting of LV endocardial thrombus or patient instability. So after 2 EPs agreed that it'd be reasonable, we assembled all the data that we could. So if the patient had a cardiac CTA, a cardiac MRI, an EKG, a NIPS, an EP study, anything we could find to localize the VT and localize the arrhythmogenic substrate. And then we would, as a group, discuss where to ablate. We would translate those findings with our radiation oncology partners onto a planning CT. From that planning CT to treatment, we're averaging about 2 to 3 days turnaround time. And then we follow every patient up at 3 months with an echo and chest X-ray. There was some initial, actually, preclinical data in animals that treatment with radiation can be prothrombotic. So based on that, we've put all patients on some sort of oral anticoagulation, and then we've been following them all up in clinic for a minimum of 1 year. And these are our results, and you know, these will be at Heart Rhythm Society in July. And there have been some changes since then, just with longer follow-up. But we've seen a very good antiarrhythmic effect with the treatment that we've offered. So in follow-up, we've significantly reduced the number of ICD shocks, significantly reduced the number of sustained VT episodes. And if you look at any events, we've seen a reduction on the order of 90 to 95% events, you know, including any device ATPs, ICD shocks, sustained VT that wasn't treated. We haven't had any short-term known side effects, so some of the concerns were radiation pneumonitis, pericardial pleural effusions. Some of the long-term side effects that we're concerned about are if radiation affected the GI or pulmonary system. We haven't seen any decline in ejection fraction. We've had 2 patients pass away, one due to a pneumonia and one due to an unknown cause. But we haven't attributed any of these or are highly suspicious that any of these deaths are related to the treatment. So how do we explain these diverging outcomes? And one of the things that I want to stress is that the WashU group has been enormously helpful in starting our program, and we've closely collaborated with them, and our approach is very similar. The approach with the CyberKnife is significantly different. It's a different energy source, the dose rate's different, and the targeting is different. And it is not surprising to me that the results are different there. So the results from Texas Heart, I think, could be attributed to that. Some other groups, I think, are likely treating different patients. Other things that we're seeing is that the way we do motion estimation versus other groups is significantly different, and this may account for some of the differences that we see in outcomes. And there's an upcoming randomized trial that's sponsored by Varian that we'll be participating in that will hopefully help answer some of these questions. So where do I think this therapy will end up? And I think this is really a question of where aren't we succeeding with catheter VT ablation. And Jacob's talk was amazing, and it may be that pulse field catheters in a few years really reduce or eliminate where we fall short with VT ablation. But currently with non-ischemic cardiomyopathies, we see a high recurrence rate. And I think this is not due to anything we control. I think that in non-ischemic cardiomyopathy, the substrate for arrhythmia is very diffuse and patchy, and we don't have currently the tools that we need to target that. The other thing that we struggle with is that our procedures currently are very destabilizing, and that many of these patients are in class 3 heart failure, and that we have trouble getting them through the procedures. And Pasquale has wonderful literature on acute hemodynamic decompensation during catheter ablation and risk predictors for that. And so I think in these populations where we see high recurrence rates and high risks of acute hemodynamic decompensation, it's very reasonable to consider radiotherapy because it's both safe, easy to tolerate, and seems to have some effect on these patients. And so the short-term risk profile is very, very good. There's some conflicting evidence about efficacy, but I'm optimistic as a procedure improves, we'll see better and better efficacy. The long-term risk profile is unknown, and I think that's the scariest thing to me. So around the world, there have been a few reports of long-term complications. So one at the WashU group was a gastric pericardial fistula, which was repaired with surgery. And in Europe, there's one report of an esophageal fistula. As we're learning more about this, we've moved our fields away from the stomach and the esophagus to minimize any risks that might be involved with that. The stomach is much more radiosensitive than the esophagus is, and so we're particularly sensitive to that. The long-term risks, though, for many of these patients really are irrelevant. So many of the patients we're treating come up to me and say, if you can do anything to reduce the number of ICD shots or reduce the time I'm in the hospital for the next year, it would make me happier than anything else. And I think this procedure fits very nicely with that. I think the other thing that's really, really exciting about this technology is that you don't need an EP lab. You don't need an on-site electrophysiologist. And the Varian Linac is almost everywhere in the world. Almost every country has these. And there's a possibility that many more people could be treated with radiation than could be treated in an EP lab with catheter ablation. Varian's very aware of this, and they're very interested in having countries which may not be able to afford many high quality EP labs to use or consider using a radiation-based treatment for VT, where the targeting could be done offline or even remotely. Again, the treatments take the entire time the patient is there is, probably 20 to 30 minutes. They walk on, they walk off, and many patients could be treated per day there. And when we look at the cost profile, that could be very favorable for radiation treatment. So I think there are some particularly interesting possibilities in the developing world here. I think the big problems we're facing is that we're not sure if we have the right dose. So everybody's been using 25 gray because we've seen some effect with it. It may be that 30 gray is more appropriate for some patients. It may be that even a lower dose is appropriate for some patients. We don't really understand how this works. We initially thought we were doing ablation, but more and more evidence is growing that the antiarrhythmic effects of radiation is not through ablation, but is through modification of the electrophysiologic properties. We don't know the long-term side effects, and we don't exactly know how we should target the radiation. And there are debates about this, if we should just be targeting the entire scar, if we should be targeting only parts of the scar that we think are very relevant to the radiation. And these are the things that we have to figure out to make this a successful therapy. So summary, cardiac SBRT is a promising therapy for patients with VT who are refractory standard treatment, or in patients with advanced heart failure. It requires a very good collaboration between an electrophysiologist and a radiation oncologist. It can be performed without specialized equipment with a widely available system. Scalability is potentially excellent. It appears to be very, very safe in the short term and safe in the long term, but with unknown risk profile. And a randomized trial is very much needed because what's happening now is everybody's just kind of doing it on their own, and we really do need a good trial to figure this out. And Sanjay, do I have a few more minutes, or should I wrap up now for time?
I think it's probably best to wrap up, Jeff. We'll carry on in the panel.
I'll leave it at that then. Thank you.
All right. Thank you. That was terrific. Thanks for that overview. I know we'll talk a lot about this. There is a lot of interest from the audience, but we'll just go through a couple of questions, Jeff, and then we'll take up the rest in the panel discussion. So one of the questions that came up was the time to VT suppression. I know you have shared that with us in terms of the expectations of when the arrhythmia will be suppressed from the time that they go for this therapy. So if you can address that. And then I guess the question that always comes up is, how do you really localize the arrhythmia? And that's a challenge, right? When you're trying to hone in therapy that's potentially also dangerous to the source. So if you could address those two points.
Yeah, my pleasure. So it's very interesting, and this has actually been used a decent amount in the setting of VT storm. And multiple centers have reported antiarrhythmic effects as early as 72 hours. And in the data from our own center and from WashU, we really see peak effect around 3 weeks. And not to get too into the details, but why that's so interesting is the apoptosis and fibrosis that we spoke about really doesn't occur till 6 weeks. So the antiarrhythmic effects are very likely not due to dense fibrosis. They may be in part. During that time, during that 3 days to 3 weeks periods, we often push up on the antiarrhythmic drugs, increase amiodarone even for a few weeks, add adjunctive antiarrhythmics such as mixolotine or clonidine. But it's tough. It's tough to get them through those first 3 weeks. After that time, we reduce the antiarrhythmics, a stepwise approach. And for the second question is for targeting, it's very challenging. The approach that we take now is that we base it on the scar size. If there's massive scar, we don't like to treat very large volumes because the larger the volume of the radiation is, the more organs will be exposed to radiation and the risks potentially increase. For small scars, and I can give you exact numbers on these, we can target the whole thing without much thought. But for larger scars, we usually divide it, and we use everything we have available. Invasive ET studies, 12-lead EKG. There is a rich literature on scar mapping with MRI and CT and channel prediction, and we use these too. But there's not a standardized approach right now. The way that we're planning to do it for the trial is a combination of the 12-lead EKG as well as MRI or CT data for scar identification, and sort of using those two things together to come up with a simple, predictable treatment plan.
Thank you, Jeff. That was very helpful, and I'm sure we'll discuss this more in the later part of the session. So with that, I'm going to move on to our third speaker, Dr. Pasquale Santangeli, also a dear colleague from Penn. He did his cardiology training in Italy and then EP training in various parts of the US, including the Texas Heart Arrhythmia Center, Stanford, and then finally came to us. And we were so happy that he stayed on and has risen through the ranks, is now one of the younger associate professors in the entire Department of Medicine. And he is extremely prolific with both his clinical productivity as well as his research interests, which are quite diverse. But a lot of the work that he has done is focused on complex arrhythmia ablation. And recently, Pasquale has done some really cool innovations in terms of ablating arrhythmias in scenarios that we felt there really was no way to get to the chamber of interest to target them. We used to send them to surgery, and we would explore these other options. But thanks to his innovations, we are now handling these patients in the EP lab. So I thought it'd be great if he could share some of that expertise that he has developed in the last 3-4 years with the audience. So Pasquale, we are all ears for this.
Thank you, Sanjay, for the kind words of introduction, and thanks to everybody for the kind invitation to this meeting. So far, it's been really outstanding. So when I think about unusual scenarios, of course, there are many in EP, and the more we do cases, the more unusual they get occasionally. So I will try to focus on 3 major areas that I think that are important in general, that are quite unusual, and they do represent a challenge. First of all, typically we consider a challenge when a patient lacks conventional vascular access. And of course, the most dreadful for an EP, since we're working transvenous for most of our cases, is whenever we have interrupted or absent IVC. And particularly when we have to deal with the left atrial transeptal access, because right-sided procedure can still be done safely from a superior approach. And there are papers on that as well. Then the second challenge that I want to focus on is the how to access difficult arrhythmia substrates. And in particular, I'm talking about difficult to access. First of all, because they're challenging, because of transeptal access, like in presence of closure devices or through some form of prosthetic material. When there is a double mechanical valve and you are dealing with an LV ventricular tachycardia, and therefore, historically, these have been considered no entry left ventricle, and we send to surgery. Or more recently, we can consider also radiation therapy. Or whenever the critical substrate is there, but is protected by prosthetic material. And we're going to see more and more of these patients that they, especially the congenital ones, as they grow older, they will have multiple percutaneous interventions. They will protect some critical substrate. So the interruption of the IVC is something that initially I thought was very rare, but the more we practice and the more we find this, and of course, as we lower the threshold for interventions, particularly for atrial fibrillation, we do find, and I'm sure that everybody has in their experience, at least 1 or 2 patients that we couldn't get to the right atrium because the IVC is either congenitally interrupted, absent, or because of thrombosis. And there are some patients like that as well. So typically, actually, in our experience, most of these patients present occlusion due to thrombosis because of prior surgery or prothrombotic states. More rarely, there is a congenital absence of the IVC with azygos continuation, which represents really a very cumbersome way of accessing the right atrium, because it will turn all around to the azygos, down to the up to the SVC and back in the right atrium. The group from Korea has initially published a way of getting transeptal access to the left atrium from a superior approach. And this was a very cumbersome approach, I would say, strategy, that really the time to access was about an hour for each one of these cases, and really included a Mullen sheath because of the typical right angle here, but really a manually bent Brockenbrough needle. I don't know if you can see my laser pointer. Let me see if I can. Here we go. They was bent at about 150 to 180 degrees. And by doing that, they were able to engage the fossa valis, which was defined as a really posterior and superior to the coronary sinus, to the his, and superior to the coronary sinus, under fluoroscopy mostly. And then, of course, they got access to the left atrium and they do an angiogram. But again, it was a very cumbersome procedure with only 1 transeptal access possible, and with a time to access of about an hour. It was only 2 cases reported. So we have to find a better way to do that. And of course, there is one way would be transhepatic, which involves the, of course, we have to call for help, our interventional radiologist. It's not always possible because some of these patients present status inversus, and there is not a good way of accessing the hepatic veins. Actually, they represent about 50% of our series. So really, the only option that we had was a superior approach. And here, this has been evolving a little bit over the years, but I mean, our standard approach, typically we use intracardiac echo to get our access, typically from our right axillary vein access, and the transeptal is either done from the right AJ or from the left subclavian most of the times. But this is typical what we find in terms of the setup. We have the intracardiac echo that is, of course, flipped upside down from the right subclavian, and we have another dodecapolar catheter just for fluoroscopic reference. Typically, we use a deflectable sheath, in this case, the Achilles. It's quite crucial. You will see that to deflect the Achilles, you have to pull back the dilator almost inside the sheath, otherwise you won't be able to deflect it. This is a short Achilles that is typically used for the epicardial procedures, but in this case was used because it gives like a tighter bend, and we can engage the fossa valis just with the Achilles and with the dilator. So basically, the way we do that, we advance the Achilles at the coronary sinus ostium at this level, then we pull back as we counterclock the Achilles, and then we engage the fossa valis. You can see tenting here. Once you get to that point, of course, you cannot use a needle. As soon as you put a needle there, you will dislodge the Achilles down. So we tried with that. In the first case, it didn't really work. So we decided to cross over to a radio frequency wire, which is one that is being used for disobstructing at CTOs. The very first cases were done with a straight wire. And more recently, we partnered with Baylis, and they came up with this wire, which is FDA approved. Is a pigtail wire that is insulated all the way to the tip of the actual wire, so you can deliver radio frequency from the wire. As soon as you perforate the septum, then the wire curls, and the stiffness of the wire is very similar to an extra stiff Amplatz. So once you have the wire inside the left atrium, you can track down the dilator and the sheath inside the left atrium. The time to access with it is fairly short. Now it's about 10 minutes on average. And of course, since you're working entirely over the wire, it becomes extremely atraumatic. In this particular case, we use one of the early larger pigtail wires that are used for mitral clip interventions. These are called the Torre wire, but the concept is the same. After you perforate the septum, you advance a wire that is there's a pigtail, and then you can track the Achilles and the dilator and the Achilles over this particular wire. And again, here, this was a mix of the very first cases and the last cases, but there's a learning curve. Now it really takes about 10 minutes. And we've been doing also dual transeptal access in some of these cases. There was a observational series that we published a couple of years ago, 15 patients, mostly with paroxysmal atrial fibrillation. Most of the cases were done with a single transeptal access. Basically, we do map with a multipolar catheter with the same access, and then we change with an ablation catheter. And again, but there is a portion, specifically the last one, we've been doing dual transeptal. I don't think it's really necessary. The time to obtain the transeptal access, it was about 16 minutes. Right now, it's actually close to 10 minutes because of we're much faster now with the steps. And the procedure time and the fluoroscopy time was a little bit higher than usual. And this is really reflects the challenges in catheter manipulation from the superior approach, which is the exact opposite of what we use from the inferior approach. So typically we use contact force sensing to keep everything safer. But again, it's not any more complicated. Once you get there, it's more like a learning by doing it. But typically the movements are the exact opposite that you would use from an inferior approach. All right, let me go forward. Okay, perfect. So there are some cases that we've done actually too that we couldn't get at also for VT ablation. We couldn't get access from the standard femoral approach because of severe PAD, or in this particular case, so we couldn't go retrograde, and IVC obstruction as well. So we have a couple of cases where we also performed a superior approach. In this case, I think that's my favorite approach nowadays, is using the left subclavian whenever it's feasible to gain transeptal access. And then you can advance your ablation catheter, do point-by-point mapping, and complete the full ablation procedure like in this particular case. The other challenge is whenever you cannot get access to the left atrium because you have a presence of a closure device. And the closure devices, in particular the Amplatzer, but other form of ESD or PFO closures, will be more prevalent in the future as the recent studies seem to be positive in terms of stroke prevention in select group of patients. So we'll see more of these patients. The good thing about the Amplatzer device, which you can see here, is the most common device you will see in your clinical practice for PFO closure. It's a circular device. It's got a Gore-Tex mesh actually, and which you can also dilate in case you have to go through it. But typically, the PFO is superior and anterior, So this leaves in the inferior posterior portion of the fossa vallis, it will leave a little area that of uncovered septum that you can typically access in most cases. And again, very rarely when the unplatzer is oversized compared to, or the septum is small, it really depends which way you look at it, but typically you find a small proportion of patients where the unplatzer closes the entire septum and there is really no way to get to the left atrium with a standard transeptal approach using the inferior posterior portion of the uncovered septum from the unplatzer device, and you have to use a direct puncture through the unplatzer device. The benefit of this is that, so you have to do a couple of things. You have to make sure you're puncturing in the periphery of the device because the mesh becomes easier to dilate. As you get to the center, really, you see there is more metal here, so it's more difficult to go through. So always target the periphery. But again, this can be very easily dilated with multiple dilators or also with a balloon. Typically, we use a 4 to 6 millimeter balloon width. And after the procedure, typically this adds some form of elastic recoil or the unplatzer that go back to the primary configuration. So typically, we don't see significant shunting after the procedure. The most challenging approach, I would say, a transeptal that we have to do typically involve Gore-Tex patches. And again, this can be an ASD closure. We are talking about surgical patches or even like baffles, in particular the master baffles, because they tend to have heavy calcifications with time. For some reason that I don't fully understand, the master is more difficult than a Fontan baffle, for example. They're heavily calcified. Typically, we do a CAT scan up front to see the areas of calcification to understand whether there are some areas that are not calcified that we can cross. But again, the approach that we use for these particular cases, typically we perforate with a wire, and we can use either a radio frequency wire or the back end of the Anagilus wire, which is very stiff. And then over that, we try to cross with a small dilator and then exchange with a longer wire that is also curled, so it's safer. And then we use a balloon. Typically for a deflectable sheath, you want to use a 6 millimeter balloon, a non-compliant balloon, typically we use. And after that, you deflate the balloon after you have dilatation of the septum, and then you can advance your Achilles or your sheath on the other side, like in this particular case. See. So finally, I'll talk about another challenge, patients with double mechanical valve. And again, here, for some reason, sorry, this is not playing right. But again, this is a challenge that we see occasionally. Patients with LV, ventricular tachycardia, you see here, the bottom left, there is an apical aneurysm with some calcification and double mechanical valve. For years, this has been considered a no entry left ventricle. And the options were typically either surgical ablation or surgical apical approach that always requires Coumadin warfarin discontinuation and with some risk of bleeding. Plus, in this particular case, which was actually the first one that we have done, they was discouraged by our surgeon because there is a lot of calcification there, and they felt that going through the apical approach wouldn't be safe because it was difficult to close with all those calcification, but also to go through it. And more recently, of course, one option would be radiotherapy. But again, I think more work needs to be done in that sense. So we had to come up with a solution for these particular patients. And we learned from congenital heart disease patients, really, there are some form of VSD communications that we can use to our advantage. In particular, the Gerbaud defect, I'll review that very in the next slide. But basically, this technique does involve a direct puncture of the inferior and medial aspect of the right atrium that is close to the inferior septal process of the left ventricle to effectively create a VSD that communicates between the left ventricle and the right atrium. This is an example of a surgical procedure for correcting the Gerbaud defect. But I mean, here what I want to show you is that this right posterior and septal to the septal leaflet of the tricuspid annulus, and you see the diagram here on the right side, there is a portion of the inferior septal right atrium that is in direct communication with the left ventricle. That's why the typical teaching is that the posteroseptal pathways that you can get from the coronary sinus ostium, they always insert to the left ventricle, just because right below there you always have the left ventricle. There is no right ventricle in that specific location. So there is a portion of the right atrium. There's actually quite a large portion, I have to say, if you look at intracardiac echo, that you can use at your advantage to create a communication between your right atrium and the left ventricle, bypassing the mechanical valves in the aortic and mitral position. So this was a procedure that has been, of course, I would say ideated in the anatomy, I would say from the Gerbaud defect, but it's really guided entirely by intracardiac echo. This is a specialized view They will come up with, I would say by serendipity, when actually is a view that I used to use for septal substrate ablation, but now we use it for transseptal access as well. So here you see the ICE probe is typically located at the inferolateral right atrium. Basically, you want to be lateral, it will be inferior, and the ICE is counterclockwise tilted, so you can see a modified, I call it a modified 4-chamber view. It's 4-chamber because you see the right atrium, you see the septal leaflet of the tricuspid annulus, you see part of the right ventricle. It's actually a 5-chamber view because then you see the left ventricle here, part of the aorta, and on the back here, you also see the coronary sinus occasionally. So it's really a modified 5-chamber, but typically this is the view that you want to have. This portion here is inferior to the non-coronary cusp, where the non-coronary cusp would be, and more septal than that, actually, right outside the coronary sinus. And basically, this is the area that you want to perforate to access from the right atrium inside the left ventricle. So we typically bend our sheath in that location. We use a large curl agilis, which again provides us quite a good stability, and we can also put it in contact with the specific location. And then the access is typically done with a radio frequency wire. Again, this is just a RAO and LAO view, which is helpful, but not so much, I would say, because a lot of variability. Really, you have to use intracardiac echo for this type of procedure. But again, it shows you where you are. You are inferior to the aortic valve, slightly more septal than the septal leaflet of the tricuspid annulus, and right outside the coronary sinus. So I mean, we don't use any fluoroscopic markers because we use intracardiac echo. The perforation is done with a radio frequency wire. And here you see a straight wire from the same company. It's called Bayless. Again, it's a straight wire that is insulated to the tip of the wire. Typically, you can advance this wire very easily by applying radio frequency 15 to 25 watts for 4 to 5 seconds. Before this wire was available, you can get the same job done by using the same wire that comes with the Gillis, but you have to use the back end of it, the stiff end of it. You can apply electrocautery as the hub of the wire, and then you can advance your wire through the septum. We did one case like that before we crossed over to this, just because this one is designed for perforation, and the other one was a little bit too complicated to use. Anyhow, once you have the wire perforated, then you'll see here the track between the right atrium and the left ventricle. Then you use this wire as a rail to advance a little terumo catheter over it. It's called a glide cath. And let me see if I can show you this video. Perfect. So the wire is looped in the left ventricle. This is the radio frequency wire. Then we do advance a glide cath, which is a 4 French catheter inside the left ventricle. We pull back the wire, we verify access. Occasionally we do an angiogram, or we just connect to pressure. Of course, you're going to see the LV pressure tracing at that point. Then you exchange with a stiffer wire. Typically we use an Amplatz wire. And over the stiffer wire, we load a balloon, which is typically 8 millimeter now in width. Even though the Agilis would be just a 6 millimeter really outer diameter, we have to use a bigger balloon in this case because there's a lot of elastic recoil at that location. So you want to create a bigger septostomy before you can actually advance your sheath safely in the left ventricle. Again, here you see, this is the area that you can see a waist on the balloon. We're going to stay on. Typically, it takes about 10 atmospheres to do this. See, actually, the septostomy has been completely dilated now. And then we use the balloon as a rail. We deflect the balloon at this, we deflate the balloon at this point, and you'll see the balloon is coming down. And when it's completely deflated, we use the sheath to advance the sheath inside the left ventricle over the balloon, just like we do over a wire. You'll see now. So the balloon is coming down now. And then as it comes down, we try to push the sheath forward as we recapture the balloon. And you'll see the axis in a second. There we go. So the balloon is really used as a wire. It's a balloon over the wire, but I mean, you dilated the septostomy. After you have the access at that location, then you pull back the wire, you can do your full procedure like you always would do. So at the end of the procedure, we studied this quite extensively with intracardiac echo and also with the TT at the day after the procedure in 1 month. Our experience is that the size of the transeptal access, even if it was an 8 millimeter balloon, typically goes down to about 5 to 6 millimeters at most, sometimes 4, by using the vena contracta. And the reason why that happens is because of the spiral configuration of the septal fibers. There is a fair amount of elastic recoil in that particular location. And I didn't show you the data, but again, typically in postoperative day 1, you don't see the shunt any longer. We saw it only in about 30% of cases. And again, at 1 month, you repeat the echocardiogram, and you don't see that. But again, we had no patient with any issues with conduction system disease during the procedure, nor with any admission for heart failure. So we don't think that this type of residual shunt will cause any hemodynamic problem. Lastly, and again, we're going to see a lot of these patients, I think, in the future as they grow older. Some patients undergo multiple procedures, percutaneous procedures, particularly the one with congenital heart disease. And there is a group of patients where the substrate that represent with VT or PVCs, and the critical substrate will be protected by metallic material, like can be prosthetic material, like in this particular case, that, by the way, you see also superior access was an IVC obstruction, was a patient with a Rastelli procedure with a conduit, and then he had a melody valve on top of the conduit, and the substrate really for this particular VT was protected by the melody valve. So we've been collecting this data together with another center, and so far we have a total of 9 patients where the critical substrate, and by definition was the site of origin of the PVCs or the critical isthmus, or the diastolic activation of VT, was protected by prosthetic material, and most of the time was a metallic valve, either in the aortic position or in a pulmonic position. And these are very challenging cases because really you don't find any diastolic activity anywhere you map. So the way we've been approaching this is to create long lesions at the closest sites guided by entrainment mapping whenever possible. This is a case that I done about a year ago. And you see it was a sustained monomorphic VT, hemodynamically tolerated. This was the location up here on the outflow tract, right close to the accessible area, of the melody valve. And you see here, you have entrainment. It is an area that is basically close to an exit site because you see there is QRS fusion, but the PPI was only 5 milliseconds long to the tachycardia cycle length. And this VT terminated at this site with 3 minutes of ablation. And then we can prolong the ablation duration up to 6 minutes. And then we create a more cluster in that location. It's a very challenging group of patients because again, you cannot target the real site, the critical sites, because they're protected by prosthetic material. We also treat 3 patients with PVCs. We have 2 with TAVRs at their upper septal PVCs, and the TAVR struts were actually covering the PVCs. So even if you try to ablate at the site of origin, you won't be able with radio frequency because you're going to have an impedance error. So you have to target adjacent sites. And again, the success rate in this particular series was close to 50%, not better than that. Again, it's a very challenging group of patients. So we'll stop here and, of course, open for discussion. Thank you.
That was terrific, Pasquale. That was a rapid journey through some of these challenging cases that you made it look so easy on your screen, but we know how difficult it was. So congratulations on what you developed here. There are a couple of questions that have come up, and then we'll take up the rest in the panel discussion. But one of them is related to this point of access when you cross over from the right atrium to the LV. Is that a location where we should worry about AV block possibly happening? I know you've not observed it in your series, but what is your suggestion?
Yeah. So yes, I mean, it's a great question. And so of our 7 patients now that we've done, 50% of those, they already had heart block, so we couldn't assess it. The remaining 50% that did not have heart block, and we have seen no conduction abnormalities during the procedure or during follow-up. The reason why we didn't observe that is not entirely clear to me, because I mean, the anatomy teaching is that in that location, we should be very close to the conduction system, but we didn't find that in our particular series. So I think we're probably a little bit lower, and paradoxically speaking, we're more septal than a compact AV node would be. And one caveat with that is that occasionally by going through the location, you may hit the AV nodal artery, which is running there in about 20% of cases. I mean, according to the anatomy studies, we haven't seen that yet. But again, we were prepared to end up with heart block, but again, we haven't seen it. And I know that this has been done also now reproducing other centers. Andrew David has done a case, Stevenson has done another one, and they haven't seen that either. So I guess all I can say is that the AV node is not there according to what we're seeing, although we thought it was going to be on the way. So.
Yeah, in fact, the case that we did together, where we spent the time to create the coronary sinus ostium together with the point of perforation, I recall it was almost like at the bottom of where you would target the slow pathway. So it's like on the lower edge of that. And maybe that's kind of, to your point, that you avoid the compact node, which is a little bit more posterior and perhaps a little bit higher. Another question, and I know you are very nervous when we do these procedures about the wire causing VF. You've had that happen a couple of times. One of the questions was, the possibility of something like that happening during the wire motion. So if you can speak to that.
Absolutely. Sorry, I didn't mention that, but we've seen sustained or non-sustained ventricular arrhythmias in all of our cases during crossing. VF, I've seen it like 3 times, VT in the remaining times. In one case, the one we did with you, Sanjay, the patient was in VT terminated, so because of ectopy from the wire. To sinus rhythm and narrow QRS, there was actually a nice way of validating they were not causing heart block. But yeah, it's very pro-arrhythmic. And in fact, when we started trying to apply radio frequency on the muscle, I spoke to one of the cardiac surgeon here, which he thought we were crazy because it was going to be guaranteed VF every time we applied BOVI but I think the surface area that we cross with the wire is very small. So we are seeing that. It's not that it doesn't happen, but I mean, it's easily rescuable. Again, the space is very tiny. So even if you go into VF, you want to get your access done, then cardiovert the patient. And after that, it's not arrhythmogenic any longer. But yes, we've seen that.
Very good. Just one last question. I know you advocate for eyes. You've never done one without eyes. If this was to be done without eyes, any suggestions on maybe a catheter in the CS to demarcate that? I mean, any other way to do this without eyes?
Yes, great question. I wouldn't like to do it without eyes in particular, but on the other side, we're perforating with a wire. So I think what you need to know, what I would do, a catheter in the CS is fine, but I would also do probably a CS venogram because a catheter doesn't necessarily see the ostium of the coronary sinus. Although it's possible that you can access the left ventricle also from the coronary sinus itself, and probably nothing would happen in these cases with prior surgery. But again, we'll discourage that. So I think a couple of things you need to have. I don't think you need a His catheter because you have the aortic valve that is actually there. So you have to go inferior to the aortic valve and in between the septal leaflet of the tricuspid annulus, which you have to define in some ways, either with a mapping system or with electrograms, whatever you want to use, and outside the coronary sinus. The reason why I don't like the coronary sinus itself, although there was something that we contemplated for a while, is because as soon as you cross inside the coronary sinus, the MCV takeoff is right there, and there are big coronary vessels in that specific location. So we weren't really thrilled about that. So you have to make sure you're outside the coronary sinus, but in that space that communicates with the left ventricle, because of course you don't want to perforate the free wall of the right ventricle or the inferior portion of the right ventricle. So I think ICE is important because of that. Fluoroscopy, I guess, can be done. I believe there is a case done in Brazil, Scanavaca, that has done it only with fluoroscopy. Took longer time, but they got it done. So I guess if you're very familiar with fluoroscopic anatomy, you can potentially do it. Again, the coronary sinus, I think, is the most important fluoroscopic marker, in my opinion. Right outside the coronary sinus, yes, to be.
Got it. Well, thanks, Pasquale. I'm sure there'll be more questions coming up in the panel discussion. And so we'll move on to our final speaker for the session, Dr. Suraj Kapa. Dr. Kapa is currently Associate Professor at the Mayo Clinic. He did his training here at Penn with us, his EP training, and was a stellar fellow when he was with our program. We tried very hard to keep him here, but his interests were so diverse and so advanced. I don't think Penn really had the things that he has been able to kind of do this work on, which he's going to share with us today. So Suraj is very, very interested in the role of artificial intelligence. He currently is the medical director for the role of AI in knowledge management at the Mayo Clinic, which is really one of the pioneer centers for this. He's put in over 30 patents, some of which have translated into startup companies, and some of those companies are really focused in this area that he's going to talk to us about, which is the role of artificial intelligence in cardiac electrophysiology. So welcome, Suraj, and we are really looking forward to this.
Thank you, Sanjay, and thank you for the invitation to speak. So as we're talking about, this is going to go away a little bit from the concept of how we ablate tissue to how we potentially look at expanding what we do in cardiac electrophysiology, potentially in the next 5 years to 20 years. These are my conflicts of interest, many of which relate to AI algorithms. So everybody has heard about the concept of artificial intelligence, augmented vision for decades. In 1950, Alan Turing first wrote about whether or not machines can think, but really the concept of machines that are able to think or even outthink humans dates back millennia, even back to ancient India and ancient China when people talked about automatons. And it was really though the 1950s into 1960s that the concept of artificial intelligence as a phrase was coined. And part of the reason for that was the very rapid expansion of computing capabilities over the course of several decades, from really even before the 1950s up to today. And so you might ask, well, if this has been around since the 1950s conceptually, then why is it only now that we're seeing its advent into medicine? For one thing, I would say it's actually not the case that it's current. In fact, there are papers dating back to the 1980s and 90s from various people in JACC and other journals showing that things like deep learning and neural networks might be able to identify the presence of a myocardial infarction better than ER physicians. But what's changed over the course of the decades is the capability of computing power to be distilled into very small form factors, watches and phones, where if you go back even 2 decades ago, you would be writing all of your notes on paper. So actually deployment of the insights that artificial intelligence was capable of has only recently been able to be mass available to clinicians at the point of care. And with that, we start finding that we can come to certain insights that might improve overall health. So one of the problems we deal with healthcare today is the fact that the number of humans all over Earth are more than what our capabilities are within healthcare. And the issue is that what happens is we can only build so many brick and mortar enterprises, and we can only train so many clinicians to meet the needs of everyone. In fact, in the US alone, 80% of Americans admit they delay or forego preventive care. And almost a quarter of Americans don't have a personal doctor. In fact, if you look worldwide, about 50% of humankind does not see a doctor between the time they're born and the time they die. So the question is, how do we scale cost-effective insights? We're talking about all of these amazing technologies that are coming out, but how do I get them to the people who need them when they need them? And how do we identify them? And how do we get them even before they need them so we might be able to offer more cost-effective approaches to deal with them early? And that's where we go beyond human interpretation. We talk about applying clinical intelligence, those that Dr. Santangeli and Dr. Dixon and everybody here are able to apply when they see a patient in front of them, combined with a sort of machine intelligence that actually takes insights from the millions and up to billions of patients we all have seen over the course of decades and create a sort of medical intelligence that's far superior to either one by itself. But there are keys that are needed for successful AI applications in medicine. We need reliable large data sets, which is where Mayo's been able to leverage a lot of the data that's been existent for decades. In fact, our earliest ECGs, for example, that are available in digital format are from 1999 with appropriate annotations. The arbitration of diagnosis or the endpoints kept minimal. The problem is if you need somebody to read every single ECG and point out every single waveform from the beginning, then you're going to need billions of people to go over billions of data sets to have any sort of timeline within which that data is available for computer analysis. We need to minimize bias. Within Mayo, actually 90+% of our population is non-Hispanic Caucasian. And how transferable are those insights to other populations like India, China, Africa, and others? And finally, we need algorithms that are dynamic, that can evolve with time. So one of the areas I'm going to focus on first to explain to you where we've been evolving in is AI-enhanced ECG interpretation. So traditionally, we think of AI as streamlining human capability. Can we allow for reading the chest x-rays on site faster without having to go through radiologists? Can we do first pass interpretation faster? Can we make it scalable? But one thing we've been looking at is, can we go beyond traditional human capability? Can we see what a clinician might not be able to and create a value-added read of, for example, electrocardiograms for the electrophysiologist, the general cardiologist, or even the primary care physician? So we move beyond normal, abnormal, and get clear insights beyond that. And really, one person who's taught many of us, Mark Josephson, was a perfect example of this. He often appeared to be able to go beyond what a clinician could traditionally see. He was able to look at an ECG and say, oh, that's Miss So-and-so. She aged 20 years since I last saw her, from the electrocardiogram. But explaining exactly what he's seeing was extraordinarily difficult because it resulted from many, many decades of exposure and thinking and integrating data as he found it. Now, it's important to understand what machine learning and deep learning is. And what I find in reviewing a lot of articles and seeing what other reviewers write, there are some misconceptions. There's traditional statistics where we kind of say 1 + 1 = 2, linear correlations, etc. We have machine learning, which might often involve feature extraction, somewhat human engineered, and there's somewhat human supervision with that. Then we also get to deep learning, which includes things like neural networks, which can be partially supervised or completely unsupervised. And I'll show you an example of that. So everybody knows what this is. This is the traditional electrocardiogram. You might read it and say it's normal sinus rhythm, normal ECG. But what we found using hundreds of thousands of patient examples is that we can identify potentially a low heart function just from that 12-lead ECG, just from a normal sinus rhythm ECG, what the likelihood is that they have atrial fibrillation, and even potentially how old the person is. But you might say, well, why don't we just ask? But what we find is that how old somebody is being found in the context of how sick they are, what their actual biologic age is and not the chronologic age, and there's evolving data suggesting and supporting that notion. So with low heart function, we published about 2 years ago that the AUC for predicting a low heart function less than 35% was about 0.93, and I'll give some context for that. The risk of atrial fibrillation from a normal sinus rhythm ECG, an AUC of about 0.9. And for clinical context, a perfect test by an AUC is a value of 1. And obviously, AUCs above 0.9 compare favorably with very common medical tests. Mammography for breast cancer is 0.85. A PSA for prostate cancer, which overdiagnoses, is 0.92. And we are doing further analyses prospectively of the accuracy of these particular algorithms. But another area which we talked about briefly was physiologic age. And what we found was that just training over 1 million ECGs, the machine was able to predict somebody's age within a standard deviation of 7 years. But the more interesting thing in these patients is the outliers. And this is an example of one of them. This was a patient at the age of 38, had already had his first myocardial infarction, had several more over the years, such at the age of 53, it predicted his age was almost 70. And then he has a heart transplant. And all of a sudden, the heart coming from an 18-year-old, it predicts his actual ECG predicted age is 50, even though at that point he's 55. But then he goes on to realize what he needs to do to better his own life, loses weight, his diabetes goes away, he gets off his high blood pressure meds, and with that, his age falls even further. But the reality is, how is this scalable? To get an ECG, somebody still needs to see a clinician. And that's where we get to the Internet of Things. There are a wide variety of form factors that are facilitating our ability to get ECGs. Many people might have seen this, Cardia, which is, I think, increasingly available in India, the Apple Watch. And in fact, there's even underwear that can get continuous ECGs and transmit it to your phone. And if you think about these underwear models are actually about $5 a piece. So if you can get a clinical grade ECG from a $5 wearable, then the question is, how are you going to interpret the data from it? Just to kind of go off the beaten track a little bit, this is an example of unsupervised training I did with one of my colleagues who actually, just to put context about the role of engineers who don't have any medical expertise, his area of expertise is actually cyber warfare. But what we did is we took a lot of the work he did on cross-correlative lag analysis and linear inversion methods to say, let's just feed thousands of electrocardiograms, not tell the machine anything about what an electrocardiogram is, what a heart looks like, but say, based on relative lag of information of the peaks and the troughs in each of these signals, let's try to predict where V1 through V6 would be. And what it found is it actually had an accuracy of predicting normal looking ECGs just based on its own interpretation of what a normal lag analysis is with an accuracy of over 95% without any other information. But the leads that would be thrown out of place in a two-dimensional schema would correlate to some degree with the presence of those abnormalities, such as predictive accuracy of over 70% for identifying right bundles or left bundles, which you can debate is better than some medical students and techs. And that's where we start finding interest in unsupervised learning. In fact, there's a learning model on language called GPT-3 that was trained essentially off of all the publicly facing language on the internet, which is actually able to answer queries almost as a human would. It doesn't necessarily pass the Turing test as of right now, but we're actually training it off vast troves of medical data now that isn't forward facing to see if it can respond to you when you ask, hey, should this patient with hypertrophic cardiomyopathy get a defibrillator? And you feed it the patient's chart, and it doesn't just tell you yes or no, it's actually able to explain why and which guideline-based evidence are supporting it. Within the electrophysiology lab, this is another example where we're doing Pearson correlation with just raw electrograms without any other context behind that information, and seeing, can we in a two-dimensional framework understand where those electrograms are arising from and how they correlate with one another in space, such that we know exactly when the ablation catheter is approaching any other area that we were interested in or worried about approaching. Where might this be interesting? Say we want to take all of Dr. Dixit's ablations historically, because he might have a success rate of 95% and somebody else might only be at 70%. We want to understand what's driving his success, but he can't sit there and teach every single person on earth exactly what makes him 95%. So instead, we're able to input all of his information from all of his recordings, from all of his procedures, to then inform people as they do their procedures how to get to where they need to get to be successful, whether it be the catheter manipulation or even you're in the right spot or not. Ultimately, what we seek to achieve with all of this is better signals through novel miniature effector devices and depending on boundless computational power to ultimately improve how we deal with the overall electrophysiologic states. Some of the principal questions that I may answer, is noise actually noise? And this is a key point when we talk about electrophysiology. We keep saying, oh, that's just noise, or oh, just change the filters, let's forget about that. But oftentimes we're filtering signals that might matter, autonomic signals, neural signals, and others. Are we losing fidelity for human biology, focusing on humanly visible signals? In other words, there might be very subtle signals that we actually try to erase by filtering, or we just try to ignore, or we might not even recognize because of the ability of the human eye, that might be relevant to the human biologic state, that might be relevant to that particular isthmus or to atrial fibrillation even. How do we harness computing technologies to beyond? We need vast troves of data, we need to integrate it. What's needed to move further? We need to source large-scale, well-annotated digital data. This is something Deepak and I have been talking about within India. We need to have coordinated studies of implementation. It can't just be, let's just plug a bunch of stuff in and see what pops out. We need to understand, validate, and go from there. We need methods and devices to scale those insights because they need to have some integration into our underlying structures. We need to integrate into Cardo and whatever electrogram acquisition system we have to give those insights to individuals. Key hurdles to overcome are data security. People don't necessarily love to share their data with one another. Common usage versus intellectual property. Balancing partnership, patents, and platforms. When many people are working on the same thing, they might not be comfortable sharing all their data with one another. And actually one great example that Deepak can comment on as well is we did a multinational global COVID ECG project where we brought data together, ECGs together from across the globe, over 40,000 patients with COVID, to see if we could predict who would have COVID and who wouldn't from the form factor of a single lead ECG, and found we can predict the absence of COVID with the negative predictive value of over 99%. And ultimately, we need to be focused on the patient. It can't just be doing AI for AI's sake. We need to think about how it relates back to the clinical ability to provide care. But I'll stop here so we have plenty of time for the panel discussion. Thank you.
Well, Suraj, as always, you did not disappoint. And this was just terrific, mind-boggling at the very least, but just the stuff that you put out there, I think is giving the audience a little bit pause to absorb it. And while they are coming up with the questions, I'm going to try to get you to at least tell us, where do you think in EP you can apply what you just shared with us almost immediately? The ECG is one. But where else can you see the role for it, like now?
So actually one key example where we're working on it now, and we're working with Sanjeev and others, Sanjeev Narayan and others, is discriminate different types of signals from one another? How would you define a lava? How do we find isolated lake potential versus a split potential? You know, we're on the septum and the patient has a left bundle branch block and you interpret it as a split potential, but it's really parallel activation of RV and LV because of a phase shift and timing of activation. You might label it as an abnormal signal, but it truly isn't. Can we train a system to automatically recognize those signals as abnormal? So especially as, you know, more junior electrophysiologists or others are coming into this field, don't necessarily have the same support as they're starting their own programs, it can highlight to them what's relevant, what's irrelevant. Another example of that is actually annotation of the EGMs. So we're doing a large scale project looking especially at these complex EGMs, about how we annotate them and how different people annotate them. So we can kind of start understanding what the actual relevance is in terms of the timing. So when we try to create these maps, we're not left to our own devices to say, well, maybe it's here versus here, and then having to try and go back, especially on these 10,000, 100,000 point maps, which that would be feasibly impossible. And I would say the last one, which is oncoming, but might take another year or two to get to, is one thing we think about when we think about EP is when we create a full map, say of the ventricle, say we create an RV, LV, endo-epi map. In principle, if we have the appropriate activation and enough signals obtained, and we know where all of the leads are from the electrocardiogram perspective, we should be able to verify that our map is complete. Right now, we assume the map is complete based on, oh, are there any empty spots? But shouldn't we have a better valid way of doing that, which is the electrocardiogram, which is recognizing everything the heart is doing from a far off distance? So one thing we're developing is a way for people to know that the map is sufficiently complete. Even if it's not complete, the computer might be able to relatively fill in the areas that might be straightforward or simple. Sometimes we have a large swath of purple and anterior infarct, you missed a portion of the inferior wall, we say, well, it's probably fine. How do we know it's fine without making the effort to go there, or by validating that the computer can fill in that area because it's not sufficiently complex as to take away from what the ECG that appears should be generated as?
And you know what might also be very cool is using machine learning to kind of hone in with arrhythmia localization, and something like that could be very complementary to what Jeff talked about, where you have an alternative form to treat arrhythmias, but what's lacking is precise localization and targeting, and that's where the two worlds could come together. It'll obviously be at the peril of all electrophysiologists. So I hope that's not going to happen anytime soon, because not all of us have the ability to become you. So let's hope for that to happen, but maybe in the next 10, 15 years, speaking for myself.
Thanks, Sanjay.
All right. Well, so this was terrific. I mean, congratulations to all the 4 speakers for the wonderful presentation. I learned so much, even though I spend a lot of time with these members on a regular basis. So I imagine that the rest of the audience also enjoyed this. But I think we now can move on to the panel discussion, for which I'm going to invite my colleagues, Dr. Vora, Dr. Lokhandwala, Dr. Padmanabhan, and Dr. Selvaraj to join us. And you can please take it in terms of how you want our faculty to interact and whatever questions you have. And I'm very grateful that the faculty have stayed on, because I think this is going to be the next exciting 20 minutes or so where we can really brainstorm. So welcome, and go on, Dr. Lokhandwala. Perhaps you want to run this one?
Well, I wanted to take off from what you said about, fields coming together. For example, if Dr. Suraj comes together with Dr. Jeffrey, and between the two of them, they localize the arrhythmia and eliminate it, then electrophysiologists might become redundant.
Right.
But
right.
It was amazing. I mean, all talks were amazing. They were really cutting edge. I had one particular question which probably I missed out on in the talk of Dr. Pasquale about crossing the interatrial septum, and I believe he said it's not difficult to cross the Amplatzer device. Then why does he want to avoid it at all? Then why want to go by the side if it's not a big deal? So doesn't it stretch the wires? Is it not difficult? I'd imagine a very thick tissue that he has to go through.
Yeah, that's exactly right. I mean, it's not difficult if you have, if not too difficult if you have to do it. If you, in other words, if you have no other options, it's always easier to go for a native septum when it's available. So again, that experience is limited for actually now 5 patients that we have to go through it. And it's possible because again, the mesh is designed in such a way that it's very elastic, but it's definitely way easier to go from the native septum. It's possible. And again, that can be imaged not necessarily just with eyes. TE actually works very well for these cases as well, because you have a very nice view of the septum if necessary. Yeah, so always my recommendation, always go for it for the native septum when available. And when not available, be aware that you can cross also the implanted device. Just one minor final thing, all the cases that we crossed from the implanted were implanted at least 6 months before the crossing. So the shortest we've done is 6 months, but typically it's been 1 year or more. So if you go earlier than 6 months, I cannot guarantee safety, because I mean, there is some possibility of dislodging the device if you go too early through it. So be careful about that.
Yeah, but when you do go through an implanted device, what sort of energy? I mean, it necessarily has to be with radio frequency energy, or you can just use the transcept.
Well, actually, when we tried radio frequency energy, it was really not always effective. The problem with radio frequency, whenever it encounters metal, and it just works as an RF generator, it won't be able to deliver anything. It will shunt the energy to the metal, basically, just like when we use device pockets, etc. So it's actually easier to go with a broken bone needle in these cases and to kind of push it. And the best approach really that I found is to use the long BRK needle over a short, like a short SL1, because I mean, the long needle is the one that comes for the Agilis, for example, because you have more room to push it through, because you have to go through the first disc of the implanter, through the fossa valis, and through the second disc of the implanter. And then you have to use that as a rail to then push your dilator over. So you have to have a fair amount of needles sticking out to be successful with this.
Okay, Amit?
No, it's been a fantastic evening. All the 4 speakers have done wonderfully well and given us an insight into how the field is going to evolve in the next 10 years or so. Suraj, I wanted to ask you this, that, you know, with all this artificial intelligence and machine learning, how much will we have to unlearn? You know, with the evidence-based medicine, we are tuned to randomized controlled trials and meta-analysis and guidelines, and now comes the artificial intelligence. Is there going to be a conflict, or is it going to complement?
Yeah, so I mean, what I see is it's going to be synergistic. I mean, the problem with evidence-based medicine is it's been phenomenal to improve overall outcomes, but by its very nature, it's a probabilistic science, right? We can't necessarily determine that person A is dissimilar enough to person B to not be included within the existing evidence. And our evidence by guidelines is often broadly distributed, even though when we look back at the clinical trials, we often know that a given patient will not have fit into the clinical trial, et cetera. Even for something as simple as understanding that a given patient is out of distribution from what the clinical data shows would be valuable in a sense, right? Because then we would understand that, hey, this, yes, normally for patients with XYZ, we do, you know, number 1 or number 2. This person's sufficiently different that we can't maybe have the same exact thinking. It might still be relevant and relevantly treated the same way, but might not be. The flip side of that is actually where we see it going is an augment to evidence-based medicine. If we look at the probabilistic science of evidence being ground zero, we then take each person as an individual within this probabilistic framework, and now we get to much more attuned insights into why this person should be treated this way as opposed to that way. And to be honest, I think in medicine, that's why there was so much struggle against evidence-based medicine from many, many experts in the field to say, well, I know this person should be treated this way. I don't care what the evidence shows. And sometimes they're often right, but it's because that person's sufficiently different from the evidence that's available that we need to understand that they're different and understand how that uniqueness leads to a better approach to treatment.
Yeah, I think we need, you know, from all the evidence, we need to eventually individualize treatment for a given person. And that's where I I sincerely hope that the artificial intelligence helps to customize the treatment for individual patient.
Yeah, that's definitely what we're seeking to do with a lot of the knowledge management work of how we integrate. So we're not just telling people what to do as well, we're actually informing them somewhat of the reasons for that.
Dr. Selvaraj, you have some comments?
Yeah, good evening, everyone. I think, like everyone else has said, it has been a fantastic 4 talks and really gives an idea of what we can expect in the next 5 to 10 years coming in, I think. I don't have any specific comments as such. Pulse field ablation. So I wanted to ask whether, is this only going to work for large lesions like the PVIs and probably later in the ventricle? Or is this ever going to be possible to adapt to smaller focal lesions like the bulk of cases we do, like axillary pathways? And is there a possibility anytime in the future to use reversible electroporation as a way to map like you do with cryoablation as reversible ablation?
Yeah, so thank you for the question. So yes, I think axillary pathways, at least in my opinion, are like perfect for pulse field, but we have to wait for catheters that are a little bit smaller than the current catheter so that you make a small lesion. You can't take a big catheter and make a small lesion. So it's just a matter of getting the right catheter. And reversible electroporation, with programmable generators, we have demonstrated that you can make EGMs go and come back. We've terminated flutters by giving a pulse on a critical spot and then reinduced it and terminated and reinduced it. So it's just a matter of time for that to actually get approval for us to use in a mechanistic way, so that your armamentase, you can go to a spot for a pathway, give a reversible pulse, you lose pre-excitation, and you know that that's where you want to target your energy. So 100% you'll be using that in the future. It's just a matter of time.
Deepak, you have any comments?
Yeah, I have a ton of questions though, if the panel is okay with that.
Sure, go ahead.
Sorry, let's start with Jacob. One of the questions I noted on the chat box was the question as to the difference between cryoablation and pulse field electroporation. To my understanding, cryo is still thermal. You still have to remain at the ostium of the pulmonary vein and not go inside the vein. Whereas with pulse field ablation, you would actually be able to go inside the vein itself, get your support, and depending on the size of the vein, the contact would be determined by that, thereby improving your lesion and having the advantage of going within the vein and ablating, which theoretically has a better chance of isolating that vein and eliminating foci there as compared to something in the ostium and isolating a larger area. So your thoughts on that?
It's a nice question, and it's a little difficult to answer. Cryoablation, yes, you're thermal and you don't want to ablate in the vein. So by design, the cryo balloon, if used by experienced operators, will always be outside the vein. Pulse field ablation, for sure. If we only wanted to take the vein out, we could put the catheter deep in the vein and do the job. But we also know that the PV antrum is important. And that's where PFA needs to sort of beat cryo in a randomized study when 1,000 operators are using it. Cryo has evolved over a whole decade, and now people are really good at it. Pulse field still has to do that job. I mean, I think it'll eventually win, but I just don't know which size and which catheter will ultimately displace cryo.
The other question I had for you is regarding the data. One of the USPs of electroporation or pulse field ablation, to be precise, is the ability to select tissue to ablate. Right now, there are animal studies which say that, look, we can select certain tissues. Say perhaps you can select and selectively damage Purkinje fibers, but not damage the muscle around it. So do you see the field of selectivity being improved, especially to target specific tissue and not target others?
Within the myocardium?
Yes.
That's going to be a very niche development, maybe by a company where they have
a separate dose for Purkinje fibers and maybe a separate dose for myocardium, largely PFA will win in fields where you just want to make big lesions and get along with your day. So I do think the future will be catheters with programmable generators, like we can turn up the power with RF. We'll see that someday with PFA, but that's, I think, many years down the road.
Neat. Also wanted to ask Jeffrey some questions, especially I'm pretty sure everybody on this call wants to ask that, is how do you determine what you want to ablate? MRIs are easy, right? I mean, you get a good MRI in a lot of people, you'll have a good cardiac radiologist, he'll give you a scar that is properly delineated. How do you choose how much? How do you choose what area?
That's a great question, and it's not a one with a definite answer. We find cardiac CTA, especially for patients where they have thinning of the scar, to be as useful or better than MRI. And the most common method that we actually use right now is a very basic one. And so we sort of create a 17 segment model of the heart that we all are familiar with from SPECT imaging. And we kind of choose the segments that we want based off the EKG, based off the invasive EP study. And then we choose the segments that we want to target based off of the imaging. And most of the time they agree, but sometimes they don't. Sometimes you'll see on CT or MRI some extension of scar onto the inferior wall that you might have not seen on the EP study. But there's a little bit of a debate if you need to ablate everything or just parts of it. It's really exciting though if you see these patients with a very large anterior aneurysm where there's just no reasonable way with the current technology to treat. That's a 4-minute treatment with radiation of any size. It's very easy to target the whole thing. And that would be for me in the EP lab, many days of work and very challenging for the patient to go through. There was, I don't think it was ever published, but there was a small number of patients who got a very large radiation volume at WashU, and that was associated with increased mortality. And it's a tough subject because those are the patients with the largest scars, and it may just be confounded by that. Those are the ones with the sickest heart, but the radiation oncologists do like to limit dose, so we still have to figure out a way to get the dose as small as possible while still being as effective as possible.
Do you think the dose would change as the area changes? I mean,
that's a great question. I actually argue a lot at the clinical trial. I'm not sure we have the right dose, and Doug Packer from Mayo will sometimes say, he really thinks that this should be 30 gray, and maybe for non-ischemics versus ischemics, it should be different dose. And sometimes I worry that the trial is premature because we haven't figured out some of those considerations. The counter argument is that that could be we have some effect at 25 gray, enough to be positive, and we can figure out the dose afterwards. But I think that's a very valid concern.
So I'll hold off on the fireworks and direct application, so on.
Yeah.
And my last question, I mean, Pasquale, as usual, I mean, I don't think I'm qualified enough to ask questions or I have any doubts there. Just purely anatomical, and I thought just some extraordinary understanding of the anatomy and figuring out how to get across difficult situations. So thanks for that talk. My last question for my good friend Suraj, is that, do you also, I mean, I know you talked a lot about AI being used as a therapeutic option, but a lot of your work and a lot of the work that has been published so far has also been involved in AI used as a screening option for a variety of reasons. So in a resource limited situation where you want to provide cost-effective screening for a bunch of people, say cryptogenic stroke, who basically don't know whether they've had AFib in the last month or no. Don't you think AI has a role there, and across the world for that matter, even determination of low ejection fractions on the basis of a single ECG?
And we totally believe that that's one of the high value targets of AI in medicine. One is for scalable diagnostics, which I think would also be relevant to clinicians as well. Would you rather be seeing the patient with palpitations, or would you rather be seeing the patient who says they have palpitations and walks in with an ECG showing their SVT or their AFib? I bet you would probably prefer the latter, so we can get to the higher value of care that we can provide. So, and on top of that, obviously all the early screening options, hypertrophic cardiomyopathy, amyloid, et cetera. So we definitely see that. The question with that is going to be how we leverage technology to distribute access, because it's not going to be enough to just say order an ECG on everybody, because then everybody needs to be engaged with the clinician. And like I said, almost 50% of the human population never sees a doctor between the time they're born and the time they die. So that's where we get into distributive opportunities with existing technologies as they become cheaper and cheaper, which actually India is at the forefront of this. I mean, one of my good friends, Ramesh Raskar, actually built a $5 tool that can clap onto your camera on your iPhone and actually do a full ophthalmologic examination and give you your eyeglass prescription. And it recapitulates all the $500,000 worth of equipment that you get in an optometrist or ophthalmologist office. And with newer ECG technologies, we're getting to the same breadth and scope. So I do think that there's a benefit in that. The question of how it actually gets distributed and used, and people get alerted, especially when they don't have access to see a cardiologist, are now just worried that they might have a low heart function or atrial fibrillation, but need to wait or go thousands of kilometers to find somebody to talk to. That also needs to be considered in that context.
And this involves utilization of technology, say the ECG, where the abnormalities may not be actually evident on the ECG per se. It's not something that you and me, or say Dr. Dixit, may actually look at the ECG and say, look, this is abnormal here. It's actually apparently normal ECGs where the machine is actually telling you something else to go by.
And actually, one of the questions in the chat from Dr. Kumar touched on that, which gets to explainability. And in fact, this entire concept that we can't explain what the AI is seeing is a little bit of a cop-out. Even in our papers, when we write about that, it's because it does take a lot more effort to describe it. But truth be told, using GANs or other approaches, you're able to highlight the key features of a particular ECG that says why the machine is thinking there's risk of this there based on its inherent model. It can't tell you all the weights, but at least it's like trying to explain to a high school student what a left bundle branch block is. You can vaguely say, like, oh, look at the bunny ear pattern in V6 and the negative features in V1, and this is what's making us think this, along with the length of the QRS. But what the machine will do is it can't use words right now. So instead it'll highlight, and it'll highlight the differences that's guiding it towards its decision points and what are the most important features that are pushing it that way. And in fact, that's with atrial fibrillation, one of the things I mentioned in the chat that's interesting. For many of the ECGs, the key features of the ECG that drove thinking that this might be atrial, this person might have concomitant atrial fibrillation, was the QRS, not the P wave and not the PR interval.
That's pretty neat. Those are my questions. Thank you for answering all of them.
I think we've had wonderful 2 hours, Vanita, Sanjay. We must thank all the speakers and Sanjay for putting together such a. Every speaker talked on something which was new for everyone, at least most of us, and quite amazing, to be very frank. So, Vanita, you want to make the closing remarks with Sanjay?
I think it's all Dr. Sanjay is doing, and I really thank him from the core of my heart. Sir, please go ahead, Dr. Sanjay. Please go ahead and close the session. It will be a great honor for me.
Oh, Vanita, thank you so much. Look, I mean, this is a team effort. I'm so grateful that IHRS is receptive, and I'm so grateful also to my friends who are so willing to participate in this. The faculty have taken time out from the Saturday morning, and some of them are young dads. You could hear their kids in the background. So I'm very grateful to them. Also want to, kind of express this pride that you feel when your trainees come back and educate you about things that you never ever thought about. So it's so gratifying to see Suraj kind of rise to this, this position that he is in. Pasquale, who trained with us, is now teaching us how to navigate things. Jeff, who's also been a trainee here, is now kind of evolved into this subspecialized area. And Jacob, I knew as a kid. Jacob's dad and my dad were both working in ICI. And he is, I think, like 10 or 12 years younger to me. In Kanpur, I used to see him as like this little kid in shorts, riding like, three-wheeler or something like that. And look at him now. He's kind of, at the forefront of this. So to me, it's just, very, very gratifying at many levels to bring this back home, to introduce my friends to my family in India, and then to see my proteges now kind of, doing such amazing work. So I want to use this opportunity also just to remind the audience, thank them, of course, for staying this late to, hear the speakers. I hope they benefited from it. Our last session, which will be a full year of doing this, is the first Saturday in June. And we have a really special panel of speakers who have already agreed to talk about catheter ablation of AF. So I look forward to seeing you all again. And thank you once more for taking the time to spend your evening. I hope it was worthwhile.
Thank you so much. Thank you so much, Sanjay.
Thank you.
Thank you, everybody.
Thanks, Sanjay. Thank you, everybody.
Thank you.
Good
Thanks so
night.
much.
Take care. Stay safe.
Right, you too.